Good morning.
Good morning.
Good to see you.
Great to be here.
Thank you for being here, and good morning to everybody. We are certainly in this room and the thousands online convening innovation and the power of partnerships, and we get to kick that off with our talk. So you've done enormous work globally, all the work that you're doing, and in your work, you've chosen partnerships as a way of accomplishing your initiatives. Do you want to speak a little bit on how the partnership approach, the focused approach, the why, the strategy behind that, and how that has worked for you?
Yeah, absolutely. And Jill, thank you so much for having me and welcoming me so warmly. And I want to thank Michael and everyone at Northwell. I also would feel slightly awkward if I didn't acknowledge, kind of in broader space, what we were talking about backstage, which is that I am incredibly grateful to Northwell because I delivered 3 very healthy, happy children at Lenox Hill Hospital. So it just would have felt odd to be here and to not have that personal moment of profound gratitude. You ask about partnerships, Jill, and we spent a lot of time thinking about partnerships at the Clinton Foundation. In fact, it's a kind of foundational part of our ethos, as well as certainly part of our strategic approach. And maybe I'll start by answering the question kind of at our beginning, which I deserve kind of no credit for. When my father left the White House, he was thinking about where to deploy his still kind of capacious brain and energy and his networks, kind of the ecosystem of partnerships that he'd already built. And he decided to focus on the HIV/AIDS crisis. If we can cast our minds back more than 2 decades ago, I was listening to the opening remarks from Mike about kind of calling us all kind of into the kind of fight for meaningful health equity. Access to HIV medicine certainly was a glaring example of inequity. If you were living here in New York City, odds were that you were kind of on antiretroviral medicines, you knew your HIV status, you hopefully were also in more supportive care. Odds were if you were in the global south, none of that was true. At the beginning of the new millennium, fewer than 10,000 patients across sub-Saharan Africa were actually on antiretrovirals, even though the HIV/AIDS burden was already approaching north of 25 million people in that region alone. So my father, admittedly partly prompted by me and others, who said, we think you did a great job, but this is an area where you failed to do as much as you should. Thankfully took that as a challenge and created the Clinton HIV/AIDS Initiative, which is now the Clinton Health Access Initiative. And he determined that he, along with President Nelson Mandela and kind of others who were no longer in official positions of power, but still had deep connections to those in power and who had real relationships with the private sector as well as the not-for-profit sector, could convene a novel type of partnership to really try to move kind of the antiretroviral market from what it had been, a very high-price, low-volume one, to a high-volume, low-price one. And so kind of fast forward today, the average price per person kind of on antiretrovirals in the global south per annum is less than $60. Of the close to 30 million people who access antiretrovirals in the global south, more than 3/4 of them access them through agreements that the Clinton HIV/AIDS Initiative and then later the Health Access Initiative helped broker. And that then became the paradigm of how we think about our global health work, but also our work beyond global health. How can we uniquely bring together different stakeholders to truly have kind of win-win situations, not be kind of rhetorical or aspirational, but actually achievable with very clear renderings of kind of who needs to do what, in what order, kind of in concert, and then to hold ourselves mutually accountable. And I think the accountability part is often something that isn't designed in from the beginning and is something that we actually think about quite clearly. Kind of what are our metrics of success and how are we transparent about that with our partners so that we continue to build that trust so that we can then go on to do more together. And so now it's not only in antiretrovirals, we've negotiated more than 140 agreements that touch everything from tuberculosis and malaria to kind of early childhood nutrition and kind of everything kind of across the kind of prevention, diagnostic, and treatment landscape. And we wouldn't have been able to do that kind of but for the way that our initial partnership was designed and then nurtured and built over time.
Yeah, and like this room, those partnerships can come, whether it's small tech, large tech, healthcare organizations, payers, and you've named a number of examples. Is there another example that you can give where maybe the partnership was a little different than the HIV one that specifically can speak to the healthcare landscape and what we can learn? Because those partnerships, the collaboration doesn't come right away. It has to be built. There's a bit of a long road to how do we work together.
Absolutely. I mean, I'll kind of ricochet now to something much more local, but is very close to my heart, given what I shared earlier about having been able to thankfully deliver 3 healthy children here in the city. The Clinton Foundation is one of the partnerships with the New York City Birth Equity Initiative. As I'm sure all of you in this room know, we have a maternal mortality and morbidity crisis in this country. It's shameful that we have the highest maternal mortality rate of the global south, the wealthy world, developed countries, kind of whatever your framing is. Just under 33 women die for every 100,000 live births in this country. That is kind of astronomically higher than countries of comparable wealth and development. It's actually almost twice as high here in New York City. It's just under 60 women who die for every 100,000 live births. I see some of your eyes kind of widening. If you are a Black woman giving birth in America, you're 3 times as likely to die in childbirth or in the year following childbirth. And if you're a Black woman here in New York City, you're actually 9 times as likely to die. So our absolute kind of percentages are particularly challenging and distressing here, and certainly our absolute percentages and the relative rate of kind of what Black women who are pregnant, who give birth, and then postpartum face here in the city just indicates that we have failed as a system, kind of in whatever partnerships, in whatever kind of interventions we've attempted thus far. And so recognizing that failure and thankfully not being paralyzed by it, but being kind of catalyzed to do more, the mayor's office launched the Birth Health Equity Initiative last year. I think we're now up to more than 75 partners talking about kind of clear accountability and kind of shared sense of who's doing what. It is quite clear kind of what our birth justice colleagues are doing, our birth equity colleagues are doing, what our provider colleagues are doing, what our Medicaid colleagues are doing, what our commercial payer colleagues are doing. We've started kind of with a clear focus on Brooklyn to tackle the maternal mortality crisis in Brooklyn. We very much would welcome any and all of you who would want to join this effort. We have quite ambitious targets, but we think kind of pregnant and postpartum moms here in New York City deserve nothing less. We also recognize that we need our policymakers to continue to make movement in kind of limiting risk in really important and painfully kind of idiosyncratic ways here to the United States. We know that homicide by a firearm is a leading cause of maternal mortality, one that has gotten significantly worse over the last decade in particular. We know that increasingly accidental overdose, particularly when involving fentanyl, has grown as a risk factor for pregnant and postpartum women. And so we also are very clear about, well, what can we do within our spheres and how can we kind of maximize the chance of kind of saving and protecting lives? And also, what can we not do? And where do we really need policy leaders to step up at the state and federal levels to prioritize saving and protecting the lives of expectant moms, new moms, and also, of course, ultimately their children, because we know that when a mom dies, it has ricocheted effects actually over multiple generations. And so this is not only, I think, a moral imperative for helping to save mothers' lives, it's also ultimately a real investment in our future, and certainly one that has very strong, inescapable equity dimensions to it.
We have taken that on at Northwell as well. We are also appalled at the statistics, and we've stood up about a year ago a maternal health center, and our first initiative is focusing on the morbidity and mortality in Black moms, using AI, using data, identifying the high-risk moms, following them through the end of their pregnancy, postpartum, but now also identifying those moms earlier. So that's something, again, that a partnership so identifies how we can work together. But it's not just globally, it's right here in New York, in our country, which we cannot really tolerate those types of statistics.
And I think, too, sometimes we take, it's like a rather blunt thing to say at, I don't know, 9:25 in the morning or whatever time it is. I think sometimes we take kind of schadenfreude comfort of like, oh, look how bad things are over there.
Yeah.
But actually, like, things are deeply problematic here. On any basis that I think about and care about and try to work toward on a global level, we also have real work to do here at home. Certainly, of course, in maternal mortality and morbidity, and also in, like, we may have an unprecedented number of tuberculosis cases here in New York City.
Absolutely.
Like, why are we not talking about that? And the canary in the coal mine that could be for other deep challenges kind of that relates to kind of health status, kind of access and equity, or our rising HIV cases here in the US, or our rising syphilis cases. I mean, we so often, I think, oh, things are so bad over there, wherever there is, and oh goodness, like, but hopefully we're making progress. And then I worry that obscures the candid, kind of deep clarity and honesty that we need to look at what our challenges here, and then the humility to learn from what's working elsewhere, but also, again, at the risk of belaboring it, then having the confidence to think, okay, we know what we can do, and also we can only really make meaningful, durable, sustainable shifts if we're working in partnership across the public and private sector, the philanthropic sector, the not-for-profit sector, kind of big enterprises, startups. I mean, we need kind of the whole ecosystem, of which I know so many people here are part of, to really not only make, but then secure and continue to advance progress on any area that we care about.
Yeah, you're absolutely right. And we do have that ecosystem in this room today. So let's just dig a little deeper on healthcare disparities, but specifically when it comes to innovation. We have so many innovations, technologies, new therapies. How do we bring those to underserved communities and then further address those healthcare disparities?
I think it's such a critical question. I would say, though, I think sometimes we focus so much on the new, bright, shiny thing, understandably, that then we're not mindful of how often kind of therapies that have existed for a decade or longer are also not reaching the people who need them most. And so I think this has to be part of a broader kind of conversation to both ensure that kind of innovation, whether it's in oncology or any area, is reaching kind of anyone who would need it, regardless of insurance status or zip code. And also that kind of the innovations that probably many of you were excited about, or maybe even helped pioneer, 10 or 20 years ago, are also being thought of in the same kind of breath of how to ensure that those too are reaching kind of the people who need them most. I'm quite encouraged by the Biden administration's continued focus on health equity and how to embed health equity kind of as a real kind of metric, both for kind of paying on value-based care and also on just kind of general assessment of quality in kind of Medicare, both Medicare Advantage and traditional Medicare, kind of really thinking through how to do that through Medicaid. I'm quite also encouraged that other kind of parts of HHS are similarly kind of thinking about this. I'm discouraged, candidly, that this is not yet a real focus in thinking about some of the entitlement programs that are so often kind of working in partnership with Medicaid, so thinking about Social Security and others. I continue to think it is a blot on all of us that the Indian Health Service is not kind of fully capacitated and funded, including in thinking about how innovation should be reaching truly our first peoples. And so I do have real kind of energy for the leadership, I think the unique leadership that the Biden administration has shown in thinking about how to best kind of incentivize, support, and pay for kind of innovation through a health equity lens, and also think that there's just so much more that needs to be done, because we know that our health doesn't only kind of begin and end when we're in a doctor's office or talking to a nurse or kind of in a hospital setting. And we also know that while about 20% of Americans are on Medicaid, there are a meaningful percentage of Americans who receive care through the IHS, and we don't talk about the Indian Health Service enough. And so I do think we have a lot that we need to continue to support moving forward, and also need to be broadening the aperture so that we're really thinking about everyone in this country, and that everyone could benefit from the innovations I'm sure many of you will be sharing here today. And also not to forget that many of the innovations of the last generation similarly have not reached people living whether in Bed-Stuy or the South Bronx, or people living on the Cherokee or Navajo reservations kind of further west of here.
We also really like to say we want to embed health equity into everything we do, and it can't just be a side conversation. It has to go across and be a part of the fabric of how we deliver healthcare. But I love how you talk about innovation. There are so many medical therapies that have been standard for years, whether it's cardiovascular disease, diabetes, obesity, that some of those therapies are not even reaching our underserved populations. So when it comes to innovation, we have to make sure we're doing what's standard guidelines at this point.
Well, and I so appreciate kind of that framing and emphasis. I will say, maybe because I've had multiple sick children this week and I'm really underslept and overcaffeinated.
Like all of us.
Like all of us, yeah. If you're a parent or a provider, or probably like anyone who's leading a life of purpose these days, that I found it deeply challenging that in the depth of COVID, so many more people were now paying attention to the deep health inequities in our country.
Yeah.
And that then didn't move us toward kind of the real national coalescence that I had hoped would happen in really investing in finally leveling the playing field, or whatever your kind of metaphor of choice would be. I also found it challenging, thinking about so many of the scientists and providers in this room, that while there was enormous gratitude, that seems to have deteriorated. And so I do think what I had hoped would be kind of the positive outcomes of this tragedy that we all lived through haven't yet materialized, but hopefully certainly could, if we can continue to bring more people into kind of the innovations of decades ago, as well as those that I'm sure will be discussed here today.
Right, and if we can turn them into those that are being discussed today, obviously AI is on everybody's mind, topics, it's a part of every conference we speak to. So I do believe we're at an inflection point in healthcare for sure, and probably every other sector. Tell us a little bit about your thoughts in healthcare, about your excitement, about some of the things we talk a lot about the fear factor also in AI.
Yes. Okay. So I'll start with something that I'm really excited about and proud that we are a very small part of, and then I'll talk about a fear, since that was sort of the twin parts of the question. Someone that we've been really proud to partner with now over the last couple of years, at the Clinton Foundation, is a man named Dr. David Feigenbaum, who I wrote a book called Chasing My Cure, about chasing his cure, truly, for Castleman's disease, and how he almost died 4 times, and had he not been a physician scientist, he probably would have died kind of one of those times, but he kept kind of searching for kind of different therapies and therapeutical combinations that hopefully could and ultimately did save his life. My father read his book and reached out to him. So sometimes partnerships start because someone gives you a book and you like the book, and then you track down the person who wrote the book and you say, what can I do to help? And they had a great conversation. The Clinton Foundation really engaged and has helped now David convene truly dozens of partners in part of his effort, everycure.org, to use AI to scan kind of everything we know about successful and also unsuccessful trials when that data is in the public domain, around the kind of 3,000-ish approved drugs kind of under the FDA aegis, and those that were not approved, and match all of that data against the kind of more than 9,000 kind of human diseases that at least kind of have real kind of diagnosis and kind of form around. That nets out to more than 36 million combinations of potential kind of therapies. And so to use AI to scan kind of what might work kind of when someone has a rare condition, or when someone has a condition that has been resistant to or unresponsive to kind of traditional therapies. They had their first kind of successful treatment in February. They are continuing to build their partnership. It is anchored at the University of Pennsylvania, where David is based, but certainly now has partners truly all over the globe, and importantly, partners in the global south. Because again, we don't want this type of kind of problem-solving innovation. It's a different type of innovation than I think often how we think of kind of AI as having applicability to. We don't want this problem-solving type of innovation to only be accessible to people who are lucky enough to be in a Northwell or a Penn clinical environment. And then I'll just say briefly, because I know we're at time, kind of one of the fears that I have around AI, where I recently was in conversation with Tom Inglesby, who's the director of health security at Johns Hopkins at the Clinton Global Initiative, is really around kind of AI's facilitation of kind of bio-threats.
Yeah.
We talk a lot about AI in concerns of privacy or in exacerbating inequity. All of those conversations, I think, are hugely important so that hopefully we are protecting patient privacy and we are not exacerbating inequity. We're actually ameliorating and reducing inequity. I also think in the same way that we're now having very robust conversations in Congress, certainly in the UK Parliament, at the European Union level, in the South Korean and Japanese parliaments around kind of AI's potential threat to democracy, we need to be having more kind of conversations around how do we build guardrails so that AI does not facilitate, like bluntly, a COVID or worse occurring multiple times a year. And so I would just hope that those of you that are really in these kind of AI risk conversations embed health security in them, because we're not doing enough of that. And I worry if we don't do it now, the escape velocity will move us beyond actually being able to institute the guardrails to help protect all of us.
I think that has to be part of every conversation. So parting words, parting thoughts, parting message for this group as we kick off the day, and your thoughts on this ecosystem of technology and innovation.
Well, shamelessly, I'll just say if you're interested in the New York City Birth Health Equity Initiative or Every Cure or kind of our global health partnerships, like come find us. We very much believe that we don't know much about anything except what we already know, and we always have more to learn, particularly from and with people who are kind of similarly committed to building a healthier, more equitable, and more sustainable world, and who are already kind of doing work toward that. And would also just say, again, at the risk of really belaboring, like please don't take for granted that the innovations you all were excited about when you were together last year or a decade ago have reached the people who need them the most.
That's right.
We have to keep thinking about kind of innovation accessibility for everything, because I promise you there are plenty of people here in this country who are not yet receiving what you believe the standard of care is today, and certainly don't have easy access to whatever it will be tomorrow. And I know Northwell's really focused on equity, and I'm so grateful for that, and grateful to be here with all of you today. And thank you so much, Joel.
Thank you. Thank you, Chelsea. Thank you so much for being here.